Hello, everybody. It's my pleasure to be part of this ear and e-brain joint workshop, and I thank the organizer for inviting me. I will speak about the impact of data sharing, and you know that stroke medicine is one of, I believe, the most structured medicine because we have to follow strict timelines. We have strict flow charts. We are more and more developing algorithm in order to deliver care in the best, let's say, fast and safe manner to our patients. And these are my conflict of interest. You can imagine that none of these have to do with my talk. So since I became president, I decided to have a legacy and to leave something to my successor. And together with Bo Norving, which I always have to thank, we decided to rewrite the action plan, to have a new health symbol declaration, which then became the new action plan for stroke in Europe 2018 to 2030. You see, we were lucky to be supported by excellent scientists all over Europe. And you know that this action plan was built on the, let's say, on the previous Helsingborg Declaration, but we added the primary prevention. We maintained the organization of stroke services, the management of acute care, because I think it's this focal point what create this really structured approach to stroke care. And then we added the secondary prevention and organized follow-up rehabilitation, which were already a part of the Helsingborg Declaration. We maintained also the evaluation of stroke outcome and quality assessment. And this is why we know, because we did this from the beginning, and you know, from the latest meta-analysis published by Peter Langholm about the patient-based meta-analysis, we know that dedicated stroke unit care definitely make the differences in stroke care. So and then we added life after stroke, which is new. And why we add this? Because now our patients survive and they tend to live 10, 20, 30 years with stroke sequelae, which is important to always to remind also to us, we are acute stroke physician, and we tend to forget this, that despite the fact that we saved their life, and probably we have many successful treatments, patient will have the life before and after stroke. So they will always remember the moment that they had a stroke. And then we have a separate group of prioritized research areas for translational stroke research. And the overarching target of our action plan to reduce the absolute number of stroke in Europe by 10%, to treat more than 90% of our patients in dedicated stroke units, to have a national plan to cover the entire chain. But I show you the primary prevention, which is important because remember, return of investment in primary prevention is the highest compared to every kind of treatment, and to fully implement the national strategies of multi-sector public health intervention to promote and facilitate healthy lifestyle, reduce environmental including air pollution, socioeconomic and educational factors that increase the risk of stroke. And I will focus in my talk about the evaluation of stroke outcome and quality assessment, because this is the way we started to have sharing our our data. Because when you evaluate what you're doing, you can build a strong functional and human infrastructure. You have crucial activities that provide evidence, enable improvement. You measure your quality of care. You improve your clinical skills, research, knowledge leader, and you create leadership, professional education, and you can build up a stroke care policy building. And in our action plan, we clearly stated that the measure should address aspects of care for the whole patient pathway, acute stroke care, rehabilitation, post-hospital care, secondary prevention, and registry data are a powerful research tool to confirm that randomized controlled trial evidence is transferable to routine services and can be used to address questions that could never be tested in randomized controlled trial. I can tell you our personal experience. We did, together with many of the participants, research on clinical decision making, and these results of our clinical based research, this was when to start anticoagulation in patients with cardioembolic stroke, the rough network. And from this clinical question, which was not so interesting for industry, then here in Switzerland, Professor Urs Fischer started the ELAN trial to understand when is the best time in starting anticoagulation. So from registry data, we enhanced let's say the design of randomized trials. So the target in our action plan is to assigning a named individual who is responsible for stroke quality improvement for each country and region. You see, we focused on this in our action plan. We wanted to have national and regional level system for assessing and accrediting stroke clinical service, providing peer support for quality improvement, and making audit data routinely available for the general public. It's important. It's clear, we as doctors, we don't like to be evaluated by general public, but in the same time, when you move from the point that auditing is not something that is punishing, but is needed to improve, then it's something that absolutely will also be an opportunity for us. And you know, for example, in Barcelona or in the Catalan Stroke Network, all the data are public. So, and this improved, especially we know how well our colleagues from Catalonia are working, and they are top randomizer, because they have this healthy competition between the centers. And we enhance also to collect patient-reported outcome and longer term outcomes at 6 months and 1 year, covering both hospital and community care. As I told you, stroke is a long-term disease. You will live a stroke patient will live with a sequela. Now, I don't know if you have the same the same situation, but after the COVID, our government is pushing more and more to have community hospitals where many patients who do not need hospitalization have to have the access to community hospitals. And in line, as I said, we need to have data on stroke services, on aspects that cover the whole pathway, And Diana de Souza, in 2016, before having the stroke action plan, evaluated the access through the data. It was, again, registry data or data reported by National Stroke Organization on the impact of stroke in the different regions. And you see, Europe is quite different. And I want to show you especially the what we call the success story. For example, Austria, they have high rates of thrombolysis, high rates of thrombectomy, very structured because they decided to have EVT centers decided by the government together with the physician. It was a same like in Switzerland. You decide there. Sometimes you have to decide also to close hospital which were not well performing. And you see how different are the number coming then to other countries. We have excellent data, for example, in Slovakia, in Sweden, less good data in other countries like Turkey. This was a little bit at the beginning of the EVT treatment in UK, which is I can tell you much better now. Again, you see Austria, the percentage of patients treated by IVT very high, 18%, and also very high the proportion of ischemic patient treated by endovascular treatment, which is 4%. So they're already close to what is our target. And you see data are coming down and not so well, very good in Switzerland, but you see very different situation from country to country. What we did also to collect data was the ESO-East program. You know, we don't have so many data from the Eastern European countries, so we needed to collect the data, and we wanted to understand what we can do to in a block of countries which came after the post-communistic era had a similar healthcare system and were organized in a similar way. So we wanted to see how we can enhance and accelerate stroke treatment in Eastern European countries, especially because we wanted to involve professional society, have build up quality data and other registry. And you can see we used, this is especially done by Robert Mikulik and his team in Brno, Czech Republic. And we built together with the European Stroke Organization the rescue registry, where all which serves as a quality monitoring. And you see how this was 2017 and this is 2021, increasing and impressive data all over the world. And you see the number of the participating countries, the number of patients enrolled. You see more than 400,000, more than 1,000 hospitals included in the registry. And you can monitor and you can ask the registry for all the data that you need, the recanalization, the number of ischemic attack, and so on. And this was also used by the European Stroke Organization and by the World Stroke Organization to measure the key performance indicators. So you'd see the centers are divided in gold, platinum, and diamond based on quality performance indicator, how many patients are treated by thrombolysis, by thrombectomy, but not only how many patients are evaluated for dysphagia, how many patients are treated immediately with antiplatelet, and so on. And you see the number of gold center and the number of diamond center increases. The time to needle reduces. So absolutely a success success story. And you see also some data, it's not rocket science, it's clear because it's not a clearly clean epidemiological study, but at least you have some data about the distribution of ischemic stroke, which seems also plausible in Europe, in South America, Southeastern Asia, in the MENA region. So important, at least some data from regions where we never had so many data to understand the needs of patients. So this is the, let's say, the ESO-EAST group where we started, where you see a lot of people that you probably know, and it was really a success story. And I hope it will continue as a success story in collecting the data that we need to improve stroke treatment. So I invite you to read our stroke action plan, and because this is also, let's say, the basic in order to improve stroke treatment in all Europe. Thank you very much for your attention.